30 people. I don't see everybody else. I can't. I will. Yes, yes. Sorry, a little late. Oh, sure. Make sure that this stays. Ready to start? Okay. Good evening, everybody. Can you hear me and see me? That's okay. Okay. I'm Dr. Furlong. I run the Chicago Center for Women's Health. I opened about 10 years ago. I have two offices, one on 74th and Cicero, and the other one on 90th. It's very close to each other. It's a women's health center, and obviously, as a women's health center, we do menopause. My presentation today is about menopause. Okay. So, who is menopause affect? Women, right? It's not a problem for men, even though men will talk about midlife crisis and other issues. It is a female problem. What does it mean? What is menopause? The true definition of menopause is the cessation of menstrual cycle over 12 months, 1 year, no bleeding at all. Not a spot, not a drop, not anything. So some patients will say, oh, I don't have my period, I just got spotting. I'm in menopause. You're not in menopause if you're bleeding. That's just a definition of it. You could have irregular bleeding, but it's not menopause. Well, you could be in menopause and have irregular bleeding, but the true definition is no menstrual cycle, right? Does that make sense? And it's kind of a little bit, so I can have like a 58-year-old who says, oh, I still have spotting every 6 months for the last 5 years, and she has hot flashes and other symptoms, do a blood test, but she's truly in menopause and she got irregular bleeding, but she's truly menopausal, she doesn't have a cycle, no menstrual cycle. So a little bit of a technical differentiation, and that's important because irregular bleeding can be a medical issue that has to be addressed. Next slide. Where? So where does it happen, right? Menopause, what is it, where is it, who has it? When we think of, menopause, it's not just the absence of a menstrual cycle. You can have vasomotor, which, is your whole body. You can have psychosocial, so we're talking about, brain and interactions with other people and physical changes, right? So we think of vasomotor, we think of hot flashes, and that's up to 85% of all women who go through menopause will experience hot flashes. Your night sweats are the same. So hot flashes, they're defined by heat that comes from the nipple line up and flushes up. Some people say they get from their toes up to their head, but one of the main definitions and differentiating factors between just feeling hot, that sensation of always being warm, and actual hot flush is a flush. It goes up, and it is a chemical and vascular differentiation that happens in the body. Okay, and then there's night sweats. So a woman might wake up at night and her bed linens are wet. She wakes up cold because she's been sweating all night. She's hot. She's throwing the blankets off her, and then she wakes up and she's wet. And it's a hot flash at night time, night sweats. Okay, they're very similar. Hot flashes can happen all throughout the day, and night sweats, of course, have to wake up at nighttime. Psychosocial. What are the psychosocial issues in menopause? We notice lots of mood changes, right? You get depressed or anxious with menopause, and it's biological, it's chemical. Things are happening in the brain. Hormones are changing, right? Your physical body is changing. Poor memory. A lot of patients complain or would complain of poor memory as they go through this change, whether it's because they're having lack of sleep from their night sweats and their hot flushes, or it's just a biological change. Physically, the whole body of a woman will change, right? Because if you think about when from childhood up to older age, a young girl doesn't have estrogen. She goes through puberty, she starts to get estrogen, she becomes older, she has breast development, she has pubic hair, she has her menstrual cycle, right? Those are curves, female traits and characteristics. They only occur because of estrogen. So when you turn in your 50s and you have that lack of estrogen, then that's a withdrawal of physical things in your body, right? So you start having, sexual changes, and by that I mean you might have libido changes. your desire to have sex may decrease, your orgasm may decrease, you may not be interested, maybe it may take you a while to have sexual desire, or even to have the strength of the same orgasm you had when you were in your 20s or 30s. And something, excuse me, I thought was really interesting, your aches in the joints or muscles. And I read this in several studies, which I thought was interesting because it's very specific. It's not an osteoporosis, right? It's an actual aching in the joints that occurs with menopause. So I do have a lot of patients like, oh, just have arthritis, I'm getting older. And it's not just that, it's menopause. It's something about the lack of estrogen changes our physical body. Our energy changes. You might find that get up and go is just really warm. Insomnia, again, that can be tied to your hot flashes. Your skin tone changes, you get dry. Of course, wrinkles, but you're aging in, but it's something different about menopause, not just aging. It's a turgor. It's the strength and elasticity of the tissue begins to change. Weight changes. What we see in menopause is as the estrogen goes down, the ratio of hormones that a woman has in her body begins to change. So every woman and every man have all these hormones. They just are in different varying degrees. So we have testosterone and estrogen, male and female health. We just use those two as an example. Premenopausally, estrogen levels are higher than testosterone. As we go through menopause, when our estrogen drops, the ratio between testosterone and estrogen changes and shifts. So our patterns in our body change. We become more male dominant. We might lose hair. You might find that you get more chubby around the waistline. We get male pattern cardiovascular disease. We get cholesterol changes. In fact, there's a new study that came out last week that there's a 10% increase in bad cholesterol just with going through menopause. And heart disease goes up. Obviously, kind of the male patterns that we always see with men, we start to see in women in menopause and our rates start to equalize. And then, of course, there's vulvovaginal atrophy, which is about 50%. And that means just the vagina and the skin, from the vagina to the lips and everything become drier. They become drier, they become less elastic. With menopause, and about 50% of all women will experience that. So those are all the wear changes, wear in your body. When the average age is 51 in America, but the range can be anywhere from 45 to 55 years of age. Menopause is not considered premature menopause unless you're younger than 40. So between 40 and 45, you still have some menopause that's considered normal. But if it occurs before 40, then it's premature menopause. Why? It's our biology. Nobody knows why. We reproduce at a certain time in our lives, and then reproduction is gone. Men are able to reproduce their whole life, but women, we have a very set biological clock. And why is menopause occur? It occurs because the estrogen levels decrease. Where does estrogen come from? Estrogen comes from our ovaries. It also comes from fat cells and the placenta. That's the next slide. So there are 3 types. I call it the 1, 2, 3. Very easy. 1, as you can see on the slide, is ovum. 2, di, which a lot of Latin words di is 2, but I also think of a bicycle, right? Because the bicycle has 2 tires, and then there's tri, like a tricycle with 3 tires. So if you actually molecularly, the estrogen molecule is very different, 1, 2, and 3. And those have to do with, I guess, the methanes, I don't remember. But estrone is the weak estrogen. It's small, but many of them. So when we have women who are morbidly obese, all those fat cells are producing a lot of estrogen, okay? Now, estrone may be a weak estrogen, but it can be a lot of weak. I almost think of like Toy Story. If you remember, right, the guy, you walk through the toys and all the little toy soldiers came out, and he knocked them down and tied them up for like Gulliver's Travels, right? You have a million little tiny army men that can take on a giant, right? So I always think of that like with estrone. Estrone, if you have a lot of little fat cells, they produce a lot of little estrogen. Yeah, they're small, they're tiny, but if you have a million of them, that's still a million of them, right? A million pennies. So, you have to think of quantity when it comes to estrone. Estradiol 2. There are 2 ovaries, on left and one on right. So that's the one that's the most biologically active and the one that's most potent. 3 is estriol. That's mainly during pregnancy and produced by the cells to support pregnancy. Next slide. So those are the biological components of estrogen. And I tell you that because it's important when we start looking at how do we take estrogen and what is it that we take. And this ties into when people say, well, I don't want to take hormones. I want to take something over the counter. I want something that's natural. Surprisingly enough, our body makes an estrogen called estradiol from our ovaries, and all of the synthetic that come from the pharmaceuticals are actually estradiol. So they are biological identicals that we get from our pharmacy. People don't think that, with the exception of conjugated estrogens, which are from sequestered horse urine, with pregnancy of that, which is a whole different topic. But how can you take estrogen? You can take it orally, you can take a pill, you swallow it. You can have transdermal, that means you take a patch that looks like a Band-Aid, you remove the backing and you stick it to your skin and it goes right into the blood vessels and it gets absorbed systemically. What does systemically mean? It means it goes through the skin and it travels through all the little blood vessels in your body. It goes through the entire body and then it goes through the liver, and the liver is like the clearinghouse of the body, and we break it down and start to digest it. You have topical gels and lotions, and those are typically go in the vagina. And then you have vaginal rings that also go in the vagina. Implants can be something like pellets that doctors inject into your buttocks, and they will continuously release a little bit of estrogen. So those are all the forms of estrogen, and then, like I said, you can have the biological identical, which are estradiol, or you can have the conjugated estrogens, and then of course you can have the phytoestrogens or the plant estrogens that you get over the counter. Next slide. Does the route matter? So yes, it does. If you think of when you ingest an oral pill, it gets swallowed from your mouth, goes into your stomach, and acid starts to digest it. The next route in our digestive system is that it goes to the liver and it gets absorbed and broken down. That's called a first pass. All medications go first in your liver. Okay, the liver wants to make sure that anything that goes into your body is acceptable. So it might break it down a little. So what remains is lower than the dosage that it's actually given. So you'll look at oral doses are going to be much higher than a patch. Because remember, a patch goes right into the blood vessels, right into the target tissue first, then it goes to the liver. So then you can have the skin absorption or transdermal, and that dose is higher because it passes the liver. Then you have implants. Implants are like a permanent patch. They go always into your bloodstream and eventually get cleared out by your liver and get digested and urinated out of your body or defecated out of your body or bowel movement. So implants have the highest sustain level, which is why sometimes when you look at people who do more alternative medicine use that. And it's not really on label in the United States. It's used a lot in Europe, but people do place it here. And everybody has different reasons for doing what they do. It can be safe if it's used appropriately. And then vaginal, if you use a vaginal preparation, whether you're using something that you put on the skin of the vagina or the vulva, and put it inside the vagina, that has very little systemic absorption. So if I prescribe somebody a vaginal cream or vaginal tablet that they're using, and I do a blood test, levels will be very, very low. So that means that you're not going to use a vaginal pill and have you cure your hot flashes. You need to do something like an oral or a transdermal. Next slide. So one, do not take estrogen products for menopause, for treating your hot flashes and such. You don't take estrogen if you have hypertriglyceridemia. What does that mean? That means that there's a fat molecule in your blood that's really, really high, and estrogen can make it much higher. If you have gallbladder disease, if you have thrombophilias, in fact, these are blood clotting disorders. Some of these blood clotting disorders, when you take estrogen, the blood clotting gets worse. You can have a blood clot that travels to your lung. They can form in the legs. So we don't want to exacerbate that problem. We don't want to make that problem worse. Some of the estrogens also you don't want to take if you have a history of migraines or auroras. because you have a higher increase of vascular events like TIAs or transient ischemic attacks, which are the tiny microstrokes. And then there's additional reasons that are in the next slide. Let's go ahead and switch over. Or maybe it's after the slide. So how long can you take estrogen? The new literature is saying you can take it up to 5 years, but not beyond 60 years. So if the average age of menopause is between 45 and 65, that means after 50 or 60, you quote unquote have to stop. I keep a lot of patients on medication, as long as they're making their appointments and they're having sustained benefit from it, they can take it longer. 40% of all women 60 to 65 years old have persistent hot flashes. So, a lot of people still suffer from hot flashes and benefit from hormones. So, following those guidelines can sometimes be difficult and a poor quality of life factor for a woman. Let me turn to the next slide. The implications of stopping hormones. So, the implications of stopping hormones could be vasomotor, resumption of your hot flashes, resumption of bone loss. So hormone replacement therapy helps the bones stay strong because the bones have estrogen receptors on them, and it helps in the remodulation of them. It's not a cure or treatment for osteoporosis, but we know that it definitely slows the loss of bone. It slows the loss of bone loss. It helps the bone stay stronger, although not a treatment and not a reason to take estrogen, but definitely a benefit. If you stop taking estrogen, you can decrease your risk of breast cancer because taking the converse of that is taking estrogens can increase your risk of breast cancer. And then coronary vascular disease, this is heart disease. It's plus or minus. There's a lot of literature back and forth on whether estrogen is pro heart health, or adverse heart health. I lean more towards it being very beneficial for heart health and the elasticity of the cardiovascular system. It's the progesterones and hormone replacement therapy that really have adverse effects to the heart and cardiovascular, which we'll talk about when we get to progestins. Go ahead and to the next slide. So this was the risk slide. Sorry about that, we went out of order. Risks for estrogen include breast cancer risk, coronary heart disease, which we know goes back and forth, stroke and TIAs, active liver disease, and vaginal bleeding. Next slide. The effects. What does estrogen do in the body besides some of the things we've just talked about? It can change some of our binding globulins. Binding globulins are kind of like, if you ever see people get tackled and held down, right? So a binding globulin is something in the body that the liver produces that will hold a hormone and keep it from being active. So if you have a sex hormone binding globulin increase, that means it's going to want to hold down more of the active hormone like estrogen, and therefore it can't be active. So it results technically in less testosterone, which probably with estrogen as well, but testosterone is one of the adverse effects for it. Thyroxine binding globulin is increased. So if you have thyroid disease and you're taking a supplement for your low thyroid, you have to be careful with your levels if you're on estrogen. And then you have to be careful if you take anticonvulsants like phenytoin, because they will decrease the availability of the estrogen. So you might find taking it, it's not having any effect, but you can take more because it changes things in the liver that will change the concentration of estrogen. Next slide. Progesterone. So we talked about two hormones. We talked about testosterone, we talked about estrogen. The other hormone is progesterone. So we're going to look at two hormones that are really the most biologically active, and that's progesterone and estrogen. Progesterone is the part of the female hormone that really helps with the menstruation to kind of get rid of all the buildup in the uterus. And if you have way too much estrogen, you're going to have a risk factor for cancer of the uterus. And we give progesterone to decrease that risk. Next slide. How can you take progesterones? Well, progesterones come together with estrogen. You can definitely take separate pills or separate formulations. So you can take an oral pill of progesterone, you can take micronized progesterone or medroxyprogesterone, or you can take it kind of in one pill with an estrogen, like a Moran or Prempro. It's actually Prempro. There's a vaginal gel. I forgot what that was called.
It's not used that often. We used to use it a lot in premature deliveries, but it's not something that's really sustainable for a menopausal patient. Intrauterine device like the Moran is definitely used off-label. It's a legal progesterone, and that goes ahead and delivers a small micro amount of progesterone into the uterus, and it's local, kind of like an implant, and then you can take an oral estrogen, so you get some uterine protection from endometrial cancer. And then you can do injectables like the which is not really used for menopause, but can be taken. Those are just possibilities of routes that progesterones are given. Next slide. So again, the progesterone, you can take it 12 days of the month, and you can take it every day of the month. Again, the progesterones have a little bit of adverse effects to the coronary artery system, right? The coronary heart disease. It's increased when you have progesterone. So in 2002, when the WHI study came out, the Women's Health Initiative, with the big nurses consortium, and this is when estrogens really blew up, and all the doctors stopped giving estrogen to all their patients. It was chaos. Now we had women having hot flashes all over, and instantly miserable because everyone was afraid to write another prescription for hormone replacement therapy. And mainly because the progesterones in the study were the ones that were causing a lot of the adverse effects. So we know now that there are better progesterones, and then we also know that there are risks to taking the ones that we have. Medroxyprogesterone is definitely not as easily tolerated as a micronized progesterone, which is more like a biologically compatible progesterone. And then, of course, there's the progesterone, which is very low dose and very little systemic absorption, although it does have some. Next slide. The effects of progestin. So we know that there are some effects from estrogen. For progesterone, there's bleeding, breast tenderness, mood changes, and bloating. It tends to have more of like a bad profile for taking, where estrogen, tends to help with the bones, it helps with libido, it helps with vaginal dryness, it has good cardiovascular stuff, a little bit of good mood, and then you look at progesterone, it's almost like a bad guy hormone. But it's necessary to take if a woman has a uterus to prevent cancer of the uterus if she's on hormone replacement therapy. Next slide. Conjugated estrogens. This isn't used as much. The insurance coverage for MindSelect patients are not. They're not candidates for this as much, so I don't get it. But it's a selective estrogen receptor modulator. What that means is it's a SERM. It looks and it acts like an estrogen, but it's not an estrogen. And so you're going to have, you're not going to need like progesterone because it's not really an estrogen, but it's gonna affect the tissue very similarly to what an estrogen will work in the body. So it'll help you with your hot flushes, it'll help with some bone health, but you don't need to take the progestin. So it's a nice medication. It's a little expensive, but it works well, and it's not as strong as an estrogen, but it's tolerated very well. Next slide. So menopause hormone therapy, we talked about estrogens and progestins and how they change and how they decrease and what the three types of estrogen are, and that they pretty much go to very low levels during menopause, right? That's how we get menopause. All of these hormones are decreased. So how do we treat that? Do we want to treat that? Is that just considered normal and we should go ahead and have hot flashes and vaginal dryness? You can. And I have lots of patients who are like, well, this is what my body does. It's natural, and I don't want to do anything about it. And that's fine. Unfortunately, those patients, they don't sleep well. They wake up often, and you have urinary changes, you have libido changes, you have pain with intercourse, all of the symptoms that come with menopause. And not that every woman has them, and not every woman has them to all the same degrees, right? So hormone replacement therapy is there to help with hot flashes, and over 75% of the decrease in hot flashes helps with the vaginal changes, mood changes, and sleep weaknesses. So MHT is the new coined term for menopause hormone therapy, or we used to call it HRT, hormone replacement therapy. We're just going to be a little different these days. Next slide. So remember, it doesn't treat nor prevent coronary heart disease, osteoporosis, cognitive function. Cognitive function is your ability to think and problem solve, and then it does not decrease or prevent dementia. Studies are really back and forth on a lot of these. Not so much with osteoporosis, we know that it does help with bone health, but doesn't prevent osteoporosis. But for when it comes to cognitive function and dementia, we know that it has some positive effects, but we don't give it to treat. Next slide. Then there's the genital urinary syndrome of menopause, and this is really big. It gets its own little title and its own papers and its own literature searches, because a lot of my patients who go through menopause, this is their main complaint. Their main complaint is dryness. I wipe, I urinate, and it's dry and I'm bleeding. I can't have sex, it's dry. The elasticity of my skin is gone. Right? Well, they don't use those terms, but that's what happens. Pain with intercourse, and then urinary changes, urgency, frequency, getting up at night to pee, incontinence. Nocturia is up getting up to pee at night. Next slide. Mood disorders. We know that it's increased in menopause. There's a study, Hormones Early Estrogen Prevention Study, KEEPS. It's a 4-year trial where they had 220 pre and perimenopausal women between the ages of 45 and 54, and they were treated with conjugated estrogen with micronized progesterone, and it resulted in a decreased depression score and anxiety over placebo. So we know that I don't give hormone replacement therapy to say it's going to help with your mood, it's going to help with your, your memory, it's going to help with, early onset dementia. But we know that it does something to the brain, right? Because there are receptors that are estrogen receptors in the brain. We just won't have all of those studies quite delineated as to a cause and effect right now. Next slide. Endometrial cancer. So when we look at hormone replacement therapy, everybody's always worried about cancer, breast cancer, uterine cancer. We know that the link between hormone replacement therapy and breast cancer is very, very small. I think in a patient with very low risk, meaning that you have no first degree relatives, you have no family history of it, and you yourself don't have a cancer, then your chances of having a cancer are very low. Having, self-breast exams every month, mammograms, and being preventative, right? So just being smart about breast cancer risk. And endometrial cancer is something that we see quite more often. And there's some interesting data that I wanted to include on this slide, because I think, as in 2002, when the Women's Health Initiative study came out and everybody got off hormones, because it causes cancer, because it causes heart disease, because it causes blood clots, everybody moved, women were miserable, right? You got off your hormones, you're like this instant menopause, they weren't feeling well. They moved to all the plant over-the-counter phytoestrogens, right? And I'm not going to name brands, but there are lots of brands out there that people started buying, right? The synthetic over-the-counter hormones. So if you look at this data for endometrial cancer, for women aged 50 to 74 in the USA, from 1992 to 2002, before that landmark study came out, the incidence or the rate of endometrial cancer was stable. Every year it was like 2.5%, right? Well, no, it was stable. Sorry, excuse me. Then the WHII study comes out, 2002. You start seeing an increase of endometrial cancer. Now, if prescriptions were being written less for hormones, then why does the incidence of cancer increase? Because everybody's buying over-the-counter stuff that's not being regulated. So we have an increase of 2.5% of endometrial cancer. By 2006 to 2012, the rate of endometrial cancer increases 10% a year. That's huge. Why? Because bioidenticals started becoming very popular. Everybody wants the natural estrogen, right? Because God forbid, if somebody writes that horrible prescription of chemicals that are going to give you cancer. So it's funny because everybody is thinking one thing, the actual truth of it is absolutely the opposite. When you go, the FDA went and looked at a bunch of different over-the-counter hormones. And when they looked at the biological active component in these over-the-counter estrogen products, the plant estrogen levels range from 67.5% to 268% of the active chemical. So when you go to the pharmacy and you fill an estradiol prescription I give you, you're going to get 1 milligram of estradiol every single pill, every single time. Because the FDA regulates it, because it's monitored, because it's controlled. But the FDA doesn't monitor over-the-counter stuff because they're considered plants, they're considered foods. You don't have to monitor those. So half the time you don't get the hormone you want, or you don't wait 3 times the amount of what it is. So you start seeing these women taking these plant estrogens, and remember, to prevent endometrial cancer, you have to have your progesterone comes out the womb, and you end up with higher rates of endometrial cancer. So it's unfortunate because I think what our intentions, medicine's intentions, or the study's intentions were to provide better direction. It really didn't. And here we are 20 years later, realizing that estrogens are not as bad as we thought in 2002. I remember being president when that study came out, and it was just chaos. Go ahead and go to the next slide. So the non-hormonal choices, besides the over-the-counter, are going to be your SSRIs. Those are your serotonin reuptake inhibitors. My favorite is venlafaxine or Effexor. It's citalopram. It's all the marks as well. It's not something I give this often, but all the literature says it's just as good as venlafaxine. And then black cohosh. Now, black cohosh is our over-the-counter phytoestrogen, but a lot of studies really substantiate that as a very nice supplement. It is a plant estrogen, but it definitely hits the mark. If you're going to get anything over the counter, that is something that you can buy. Comes in a pill form, or you can make it in a tea. I like it. I've been using it since the WHI study came out in 2002, and red clover, but I don't hear that much about red clover anymore. But black cohosh is nice. Just have to be careful how you're using it, but it definitely helps with hot flashes. Next slide. Oh, that's it. So that was my whole slide. Kind of went through them. Let me just kind of go over all of this really quick, because I know it's a lot of information. A lot of it's technical, a lot of it's about medications. What does menopause mean? And every person is different, right? Someone might come in and they might say, I don't feel good, my relationship's having problems, My husband always, or my partner always wants to have sex with me, and I have no desire. That's my number one complaint I hear from patients. I have no desire. Give me a pill that makes me want to have sex again like I did before. There's multiple factors for that. One is, the duration of the relationship, the stress of living with somebody, the stress of life, being sequestered during COVID, libido changes from menopause. I always tell women, think about it. Once you go through your hormone changes, you don't have the hormones that were the drivers. It's like having a car without an engine. Yeah, you can push it, or yeah, you can roll down a hill, but you really don't have the gasoline that's going to make it go anymore, right? So we have to think about the fact that, we are driven by our hormones. We are driven by things inside of us. And not everybody is so susceptible to them, but most women are. So a lot of women say that during menopause and libido changes, there isn't a magic pill. And hormone replacement therapy does not get libido back, but it helps with the pain of intercourse. And I always tell patients who suffer from that topical hormone is actually very, very safe, right? It's one of the things I advocate for most of my patients, even before they have the changes, because once the vagina gets really dry, it's really hard to get back to its health that it used to be. Other things from menopause are memory changes and lack of sleep disturbances, mood changes, all those little things. And that's kind of where, for me, that last slide about the non-hormonal component of it, a lot of times I'm not only starting with a patient on an estrogen, or they may not want an estrogen product, but I try to give them low-dose SSRI. It's an antidepressant, but it's not for depression. It works in a really different way for women. It really helps with hot flashes. There's lots of studies that show that women who are on these medications have less hot flashes or less severe hot flashes, but also helps with some of the mood changes that women experience, and that ends up being quite significant in menopause, which also has a direct relationship with relationships on the unit. Other things in menopause besides hot flashes, vaginal dryness, and mood changes is bone health and heart health, which I think are both cardioprotective from estrogens. Any other questions? I can go on a little bit more. There's something else I want to talk about, and then I'll pull up my last little part of the topic.
Helpful with like estrogen migraines, because for me, I never had before 45, I never had migraines, and now migraines are the biggest problem for me.
Estrogens are we don't want to give estrogens when a woman has migraines, especially migraines with auras, because migraines have a lot of different reasons for occurring. But when we give estrogens, it definitely changes the blood vessels, and we don't want those blood vessels to start producing little clots. So we're really careful about that. Why it happens, it could be happening from some estrogen changes that you're having.
Probably because I stopped having before my period at first,
Mhm.
only like a couple days, 3 days, and now it's in 5, 6 years now, I just started with morning. So I kind of thinking it's just part of menopause, that aging stuff.
It could be, and then, you want to always see a neurologist, right? So migraines are, even though, mostly it's women, and men have migraines too, they have them in different ways, but women, when we have hormonal migraines, you want to make sure that it's nothing that's, worrisome, so you should always see a neurologist, get a full workup, whether that's an MRI, or blood work, whatever they need to do. So you want to rule out if there's any pathology, meaning any other reason for a migraine besides just hormones. You don't want to say, oh, it's just my hormones, and then 5 years later you find out you've had something that's been pushing on the limit.
It's actually growing hormone, like cervical type thing. I know it's probably some kind of thing, but it's actually most for me. My ears go on, hot flashes, on one period is like on high, perfect. It helped me, and I know that stuff not good, but it's feeling so good, it's all stuff.
I love hormones, so you can't, it's hard to talk me out of giving them. But just make sure that you're okay with that. And then for migraines, if you're having them daily, Botox is really phenomenal. So a lot of my patients and a lot of women show that Botox they can sustain months of sustaining migraine-free treatment. You have a question?
This is all in.
Exactly. So, there was that slide that I showed that said, well, the new guidelines are to give hormones for 5 years, right? In 5 years, are they kidding me? I have patients who start menopause symptoms in their early 40s, right? So I put them on birth control until they hit their 50, till they're 51, and their FSH, which I didn't talk about labs. But their FSH is a blood test we can do to document menopause for women who are having irregular bleeding. So we can look at that, they go through menopause, we give them hormone replacement therapy. Technically, at 56, you should be up. You get a patient month, they're miserable, there's only hot flashes. I have a 68-year-old who's, still on. I have lots of ladies in their late 60s who are still on hormone replacement because they continually have hot flashes, they continue to have irritability, and they like their hormones. So I think, we know that as women get older and past 55 and 60, the incidence of hot flashes definitely decreases, and the severity definitely decreases. But some people have their whole life, and some people have their whole life very severe. And it just depends, everybody's different. Obviously, it's not as prevalent in your late 60s or middle 60s, but it definitely can happen. And so it can be forever. Some can have hot flashes forever. Vaginal dryness never goes away unless it's treated. That's just a given. The hot flashes, those can come and go. But vaginal dryness, mood changes, insomnia, irritability. Oh my gosh, I cannot tell you how many times in a day I will talk to someone about using venlafaxine, Effexor, for mood changes that are perimenopausal to menopausal. And how many times I will tell my patient, I guarantee you, I'm going to start you on this medication, and about 95% of my patients will stay on it for a while, for quite a while. It's just, it feels good. That makes a person feel like you're not going so crazy with these hormone changes. You wake up, you haven't slept, you're irritable, you don't really know why, your body's going through changes. I sat across from my patient today, and she rubbed her belly, and she goes, what happened to my belly? She says, this last year, it just kind of changed its shape. Well, yeah, because as estrogen goes down and testosterone goes up, we start having different patterns of when we hold our fat and become more a male type or apple shaped pattern in our body habits. So our hormones, they regulate our whole body. So when does it stop? It doesn't. And for everybody, it's very different. And what your symptoms are very different. Some women are bothered more by vaginal dryness or libido, some by mood changes, some by hot flashes or miserable.
On one of your slides, the characteristics of menopause and what it said dry skin. I never put two and two together because I've been experiencing that, but how do you treat that?
Coconut oil. Seriously, there's nothing you can do. So, can you ingest more olive oil? Maybe. But, once the hormones change your body, when you don't have that hormone, your body changes irreversibly. You can supplement and you can give a hormone, but you're not going to get back to where you were at 20 or 30 or 40 because your body starts to change. That natural estrogen changes. And not only that, what about all those hormones that science doesn't even know about? That we don't even know exist in our body that probably change during menopause, right? So the elasticity of your skin changes. I'm going to show you, so now I'm going to get to if you have another question, then I'm going to show you something that's going to hit home for you. You ready? Okay. So I brought my props. I love props, okay? I'm going to put them up here. So my first prop is our skin cells when we were 20 years old. And I have these big dice. I wanted them fuzzy dice, but I'm not going to have fuzzy dice. Okay. So here's a skin cell. It's chunky, it's big, right? So in our vagina, we have skin cells, and maybe we have 6 skin cells, right? Look at that, how thick that is, right? This is a big, thick layer. Now, I want you to think, this is a cell. Our body is composed of all cells, right? So, when we exfoliate, we get all the dry skin cells, right? So we all know what cells are, okay? So inside one of these is glycogen, right? So if I squish this, lots of stuff would come up, right? This is filled, right? You can see there's a lot. If this was filled with liquid, there'd be a lot of liquid in here. Would you agree? Right? Because it's a cube. If I squished it, it's got a lot of turgor. It can kind of stretch, right? If I kick it, it's really going to last, right? It's got a lot of stuff to it, right? So here we are in our 20s, here we are in our 30s. This is our skin, not just our vaginal skin, our skin, right? Then we get older, we start going through menopause, and our dice change to donuts. So we can see that as I stack my donuts, they are not quite as robust as our dice, right? So I'm going to stack 6 of them, and we can automatically see that they don't quite stack up as high, right? And if I squish this, some would still come out, right? Because it's got some fluff to it, right? It's still a little stretchy. It's not like, it's not horrible, but it's definitely not like in our 20s and 30s, right? So if a woman was having sex and she got sexually excited, there would be a lot of discharge that came out of those, right? So if the penis is going inside, it's a lot of cushion, right? It's not uncomfortable. This, you're kind of in your 50s. Well, it's got some cushion, it's got some elasticity, and maybe it's got some discharge that comes out of it, right? Agree? Now, you get into your late 60s, you're very sad. Then your 70s, you become a pancake. Okay? So I'm gonna take 6 of these. And these, now, imagine if I squished one of these pancakes. Are they thin? Would a lot come out? Are they stretchy? They're not, right? So they're thin, they're not very stretchy. There's 5. Wait. Here's our 6th one. There we go. So what happens over time? This is something I always tell my patients. We start off as dice, squishy and fluffy and elastic. We squish it lots of glycogen, which is kind of sugary, mucusy, slippery, that's why you can have sex where the penis goes in and out and it's not dry and painful and bleeding, right? We go to this, right, because we lose our estrogen. So we're trying to have sex. We're not completely dry, but we're sort of dry. There's not as much elasticity, but we can get by, right? We're gonna get by. We're women. We always get by. We make it do, right? We always treat ourselves last, right? Like we don't have time to go to the bathroom, we eat last, and then we become pancakes. And then we try to have sex. We don't want to have sex with our partner, our husband, or whoever it is, because our vagina is really dry. It's really not elastic. It really doesn't have any of the products that were in here when we were in our 20s. So this is vaginal health. This is stuff that happens because we lose a hormone. These actually, if you take a biopsy, meaning if I take a piece of the skin out of the vagina or out of the lips, you see these changes in the microscope. So what happens to our skin? What happens to our fat cells, right? What happens to our brain? If this happens just on the vagina, think of all the changes that happen in our body. How does estrogen, a hormone, change the bone health, right? Calcium, bones, how can estrogen be there? So there are things that I think estrogen does that we can't even fathom all of the things that happen. And unfortunately, as we go ahead and give a hormone replacement, it's not always the same as what our body would make. Men, they continue to produce their same hormones all throughout their life, right? They may have fluctuations in it, but they don't go through a physical, chemical menopause that women go in. So these are some of the changes that happen in our body. So when I give hormone replacement therapy and I give vaginal estrogen, I can take a pancake and I can make it a donut. I can make a donut kind of sort of like a cube, but not really. We'll never get back to this once we have our changes. But we want to hope to at least stay somewhere between here and here, right? Does that help you understand what estrogen does? My favorite analogy. Yeah, but they still don't want to take vaginal estrogen because in 2002, everybody came out and told everybody that estrogen and hormones are bad for you. They're not bad. They just have to be used prudently, right? Like anything else, right? That we have in life. In excess, everything is bad, right? So to use things judiciously, to use them responsibly, to get your health checkups, to make sure you're always seeing your practitioner, you're always getting your testing, you're always having exams, you're looking at the risks and the benefits. Because I always think, like I have my coffee. And what would life be for me if I couldn't drink my cup of coffee, right? These are the things that make me happy. They're what make your life worth living, right? And so we can't always decline ourselves from having things that make us feel good. You just have to be able to do them in moderation to where, we do things safely. Otherwise, sometimes it's hard. Like look at COVID. Everybody's staying at home. We saw all the things and all the pleasures in our life that got taken away from us. Simple things that really brought us lots of pleasure, right? And now we're starting to go back and we're doing all of these things and we're getting out there and we're realizing that this is what makes our lives fulfilled. So I think I should just take that off. Any other questions? So hormones help replace, the hormones are most beneficial for vasomotor symptoms, hot flashes, and vaginal dryness. We see absolute direct, we give it, the patient's better. How long do they last? They can last your whole life. Right? Any questions for anyone online?
What kind of age or some kind of because it's just only for 5 years.
Say that again?
Just only if it's only for 5 years.
That's the recommendation, but it's always up to the practitioner and the patient as to what they need. I've given patients many more than 5 years, and I have patients who only use it for a year. They say, oh, I used it for 6 months, I felt better, I started, taking it less frequently, and I just stopped, and I don't feel any problems. So I've got lots of patients that do that, they just kind of don't want to take medicines, right? A lot of people are very adverse to taking things, that they don't consider natural, right? That's where black hole hash is really nice, but then you get into your problems with them, over-the-counter products. So people can take them forever. You can take hormones forever, but you have no risks. It depends on how you feel, right? There's lots of literature, coming out about dementia and heart disease and all the benefits from estrogen. Progesterone's not as much, so it makes it a little bit difficult to kind of separate that, because in women with a uterus, you have to give progesterone so that they don't get cancer in the uterus. Because what we call unopposed estrogen, meaning if I just give you that one component of the hormone, I can cause cancer in the uterus. So we have to give a progesterone to balance that, to keep you healthy. And then you can go ahead and give estrogens. So the problem is that when we start giving progesterones, then that's the hormone that can have some kind of negative kind of influence on cardiovascular health. Right, so that kind of gives you more of a male pattern type of heart disease and things like that. So you can technically be on hormones forever.
Thank you, Dr. Furlong.
Well, thank you for listening, and I hope that this was informative.
Thank you.
You're welcome. Everybody have a good night. And thank you at home, everybody.
And there's some goodies out there. And if you guys take pens, I want to show you how to use this, because I'm